All right, let's talk about managing acute pancreatitis. Now, if you're studying for your clinical exams, especially in anesthesia or critical care, this is going to be a super high yield review to really help you nail those key concepts.
Let's kick things off with a number that should really make you sit up and pay attention. 40%. That is the in-hospital mortality for severe acute pancreatitis. It's just a stark reminder of why this condition is such a big deal and why having a rock-solid grasp of its management is absolutely crucial.
So, we're going to break this all down into 5 logical sections. We'll start with the fundamentals, then we'll walk through diagnosis and immediate care, tackle those tricky complications, and then wrap it all up with the essential takeaways for both your clinical practice and, of course, your exams. Okay, let's dive right in. Look, to manage pancreatitis effectively, you first have to be crystal clear on what it actually is, and, importantly, how we classify it. On the surface, the definition seems pretty straightforward, right? An acute inflammatory disorder of the pancreas. But that simple definition is hiding a huge spectrum of disease, and that's exactly why the classification is so incredibly important. And this is really the first major fork in the road. You see, more than 80% of cases are this milder, interstitial type, which is basically just swelling and inflammation. It's the other type, necrotizing pancreatitis, where parts of the pancreas literally start to die. That's the one we really worry about. It's a much more aggressive disease with a really high risk for those severe systemic complications. So how do we grade the severity? Well, that's where the revised Atlanta classification comes in. And as you can see, it's all about organ failure. Mild means no organ failure. Moderate might have some temporary issues. But the one to burn into your memory is severe. The key phrase is persistent organ failure, meaning it lasts for more than 48 hours. That's the cutoff that should set off all the alarm bells. Okay, so we understand the classifications. Now let's move on to the next step. How do we actually confirm the diagnosis and then start hunting for the underlying cause? So picture this. A patient comes in with the classic symptoms. Whether you're in an exam or on the ward, you need to know exactly what it takes to confirm your suspicion. Do you need all 3 of the classic criteria? Or is there a bit of a shortcut? And here is a huge clinical pearl. You only need 2 of these 3. A classic story and labs showing lipase or amylase more than 3 times the upper limit of normal, that's enough. And this is so important because it means you don't always need to rush for that CT scan. It saves time, it saves resources, and it avoids zapping the patient with radiation when the diagnosis is already pretty clear. So once you've got the diagnosis, the next big question is why? Now, gallstones and heavy alcohol use cause over 2/3 of all cases, but this table just shows you how wide a net you really have to cast. With gallstones, it's an obstructive problem. A stone gets stuck, pressure builds up, and the pancreas basically starts digesting itself. Alcohol, on the other hand, is more of a direct toxic injury. It just makes the pancreatic cells really fragile and prone to self-destructing. With the diagnosis confirmed, the clock is ticking. Our focus has to pivot immediately to supportive care, because what we do in these first few hours can completely change the patient's entire course. This quote just nails the central challenge of fluid resuscitation in pancreatitis. The inflammation causes this massive fluid shift out of the blood vessels and into the space around the pancreas, what we call the third space. So patients get incredibly dehydrated. But if you just blindly flood them with fluid, you can actually make the swelling worse and even cause things like abdominal compartment syndrome. It's a really delicate balancing act. And this slide lays out the 4 pillars of that early supportive care. We're talking balanced crystalloids, not just saline. We treat pain aggressively, usually with IV opioids. We let the mild cases eat as soon as they feel up to it. And, this is a big one, we hold off on antibiotics. At the start, this is sterile inflammation. It's not an infection. And it's important to remember that this field is always evolving. For example, the EpiPan trial is looking right now at whether epidural analgesia can actually improve outcomes in the sickest ICU patients. It just goes to show we're still refining even the most basic parts of our supportive care. All right, let's move into the really challenging part of severe pancreatitis, managing local complications like infected necrosis. This is where having a clear, evidence-based strategy is absolutely non-negotiable. Okay, one of the most vital principles here, and I can't stress this enough, is patience. The temptation when a patient is really sick is to jump in and do something. But the evidence is crystal clear. Early surgery in that first 2-week period is linked to incredibly high mortality. You have to wait for the body to wall off that collection of dead tissue, which usually takes about 3 to 5 weeks. It creates a much safer target to go after. So when we do have to act, we don't go straight for open surgery. We use what's called the step-up approach. Step 1, antibiotics. If that's not cutting it, we escalate to step 2, putting in a percutaneous drain. And only if the patient still isn't getting better do we move to the final step, which is a minimally invasive debrief. And look, this isn't just a good idea, it's backed by some serious, high-quality evidence. A landmark trial published in the New England Journal of Medicine showed that this step-up strategy cut major morbidity by a staggering 43% compared to just going straight to open surgery. It's a real game changer. All right, let's pull everything together. We'll summarize the absolute must-know points for your exams and for making sure our patients have the best possible long-term outcomes. Okay, so if you walk away from this remembering only 4 things, make it these. First, most cases are mild and get better with simple supportive care. Second, any sign of organ failure is a huge red flag and means you need to get critical care involved. Third, for local complications, be patient and use that step-up approach. And finally, be smart with antibiotics. Only use them for a proven infection. And remember, our job is not done when the patient leaves the hospital. The final critical piece of the puzzle is preventing this from ever happening again. That means you have to hunt down the cause and manage it definitively, whether that means taking out the gallbladder or getting the patient support for alcohol use. This whole explainer has been built from an excellent 2019 review article in BJA Education by McGuay and colleagues. For anyone who wants to dive deeper, I highly recommend checking it out. Thanks for tuning in, and we hope this helps you in your studies and your practice.